So you survive cancer, right? I mean, the grueling oncology treatments actually work. The disease is completely eradicated from your body.
Right, which is incredible.
It is. But the collateral damage from those life-saving medications leaves your daily life just completely unrecognizable.
Yeah.
And you're essentially told, well, the cancer's gone, so you'll just have to deal with the chronic pain forever.
Yeah, you just have to bear it.
Exactly. Today, we are pulling apart a massive stack of medical guidelines. We've got consensus statements from the British Menopause Society and NICE, which is the National Institute for Health and Care Excellence, alongside, some massive new clinical studies.
Some really groundbreaking data in there.
Yeah, and our mission today is to dissect the oncology clearance guidelines for local hormone therapies. We are basically cutting through the fear, the stigma, and the sheer bureaucratic confusion around using vaginal estrogen for cancer survivors.
Because the central tension in these sources is just, well, it's incredibly profound. Medical treatments save lives, obviously, but they can leave cancer survivors with these debilitating daily symptoms.
Right.
And for years, women have been told they simply have to suffer through it. Because estrogen, the very hormone that could actually heal their tissue, is strictly deemed off-limits.
Like it's a total no-go zone.
Exactly. But the data we are looking at today is actively rewriting that rule book. So whether you're a survivor yourself, a supportive partner, or even a medical professional trying to, stay updated, this deep dive is about understanding the actual evidence so you can reclaim your quality of life.
And to really understand the specific oncology guidelines, we first have to understand why this specific population of cancer survivors is so severely impacted by genitourinary syndrome of menopause, or GSM, in the first place.
Right, the mechanism behind it.
Yeah, because the treatments for breast cancer, things like chemotherapy, ovarian suppression, aromatase inhibitors, tamoxifen, their primary job is to drastically lower or just completely block estrogen levels in the body.
Right, most of these treatments are designed to literally starve the body of estrogen, simply because estrogen acts like fertilizer for certain breast cancer cells.
Oh, wow. Fertilize.
Yeah, so the goal of these life-saving therapies is to induce this state of profound estrogen deprivation, right?
Yeah.
So that any rogue or dormant cancer cells just cannot grow.
But that sudden artificial drop in estrogen, I mean, it doesn't just affect the breast tissue, it completely alters the pelvic floor and the vaginal tissue.
Oh, absolutely. It's systemic.
We're talking about severe vaginal dryness, micro tears, burning, pain during intimacy, and recurrent urinary tract infections that can literally land women in the emergency room.
Yeah, it's severe.
It feels like a double-edged sword. You take a medication to save your life by starving the cancer of estrogen, but in doing so, you're starving all of your healthy tissues too. It's like draining an entire lake just to catch one specific fish.
That is a perfect analogy.
Right. It works, the fish is gone, but the rest of the ecosystem is left completely parched.
Completely parched. And think about the physical reality of that parched ecosystem for the patient. Up to 75% of breast cancer survivors experience these symptoms.
Wait, 75%? That's huge.
It's a massive majority. And unlike the classic hot flashes, which often naturally decrease over time as the body adjusts, genitourinary symptoms are chronic and progressive.
Meaning they don't just fade away.
No, they don't. As the tissues lose elasticity and the pH of the vagina fundamentally changes without estrogen, the symptoms just compound.
They just get progressively worse year after year.
And to make matters even more challenging, the recommended duration for taking these cancer-preventing medications like aromatase inhibitors has actually extended in recent years.
Oh, right. It used to be a 5-year protocol, didn't it?
Yes. Now the standard of care for many women is 10 years.
10 years. Just 10 years of a parched ecosystem. 10 years of chronic pain, disrupted sleep due to constant urinary urgency, and a really devastating impact on intimacy.
Exactly. Finding a safe, effective treatment is not just, a matter of luxury or slight comfort. It is a medical imperative. The ultimate goal of cancer treatment isn't just surviving the disease, it's returning to a life worth living.
So how do we hydrate that drained lake safely without feeding the cancer? Because systemic estrogen, like the hormone replacement pills or patches that flood the whole body, that's exactly what oncologists are trying to eliminate.
Right, that's completely off the table for breast cancer survivors.
So according to the medical guidelines, what is the actual first line of defense here?
Well, the universal first-line recommendation for GSM in cancer survivors is strictly non-hormonal. We are talking about paraben-free vaginal moisturizers and personal lubricants used specifically during intimacy. The World Health Organization actually has very specific guidelines on the ideal composition of these products.
Oh, really? Like what?
They need to have an acidic pH to mimic a healthy vaginal environment, and they need to have the right balance of water and salts. Because if they don't, they can actually pull moisture out of the surrounding tissue, which would obviously cause further irritation.
Wow, okay. So you start with the least risky option. Hydrate the tissue topically without any hormones. But what happens when the moisturizers and lubricants just aren't enough?
Which happens a lot.
Right. The sources show that for a huge portion of women, these over-the-counter options simply fail to provide relief for that severe progressive GSM.
Yeah, and when those non-hormonal options fail, the next logical, most effective step in the medical toolkit is low-dose local estrogen. So vaginal estrogen.
But wait, here's where we hit a massive, terrifying barrier for patients and doctors alike.
The FDA warning.
Yes. The FDA applies a literal black box warning to all estrogen products. Even the ultra-low-dose vaginal creams, the rings, the tiny dissolvable tablets, they all carry this terrifying warning that lists a history of breast cancer as a strict contraindication.
Right.
If the FDA slaps a black box warning on it, why are we even talking about this? Isn't a black box the ultimate do not enter sign in medicine? Like, how can any oncologist justify prescribing a contraindicated hormone to a breast cancer survivor?
It's a completely valid reaction. I mean, it's exactly why so many clinicians hesitate and just leave their patients in pain. But the nuance lies in how pharmaceutical labeling actually works at the bureaucratic level.
What do you mean?
Well, the FDA often relies on what we call class-wide labeling. Decades ago, they took the warnings associated with high-dose systemic estrogen, the kind that enters your bloodstream and circulates through your entire body, and they applied that exact same warning to every single product containing estrogen.
Regardless of the dose.
They do this regardless of how the medication is delivered or how minuscule the dose is.
But why wouldn't they update it? If we have all these new targeted delivery methods, why does the label on a tiny 10 microgram vaginal tablet look identical to the label on a systemic hormone replacement pill from 20 years ago?
Bureaucratic inertia, honestly. It is incredibly difficult to overcome. To remove a black box warning, pharmaceutical companies or medical boards have to petition the FDA, present mountains of specific data, and navigate this legal and regulatory maze that can take years, sometimes decades.
Wow.
Furthermore, the guiding principle in medicine is first, do no harm. So for a regulatory body, it is always legally safer to just leave a strict warning in place than to remove it.
Even if leaving it in place means millions of women are denied relief because their doctors are terrified of the liability.
Exactly. The labeling simply lacks the nuance needed for specific localized treatments. With local vaginal estrogen, the hormone is applied directly to the tissue that desperately needs it. Systemic absorption, so that the amount of estrogen that actually makes it out of the pelvis and into the broader bloodstream, is minimal.
Right. The sources from the British Menopause Society highlight this beautifully. They point out that the total administered vaginal dose per year, if you use these ultra-low dose tablets, is equivalent to just a single dose of systemic oral therapy.
Literally one pill.
One pill spread over an entire year.
Yeah, and any initial tiny bump in the blood estrogen levels quickly normalizes to standard postmenopausal levels as the vaginal tissue heals. Once it plumps up, it stops absorbing the medication as rapidly.
Okay, so the theory makes perfect sense. Local therapy stays local. But the justification for walking past that FDA do not enter sign isn't just theory anymore, is it?
No, not at all.
The sources we're diving into today contain massive modern data sets that are directly defying this traditional dogma.
And this data is actively shifting the entire medical paradigm. Let's look at the Johns Hopkins TriNetX study. Researchers queried a massive U.S. health claims database.
Right.
They weren't just looking at some small controlled lab experiment. They were looking at the real-world billing codes and outcomes for actual patients across the entire country.
They identified over 42,000 women who were diagnosed with GSM after a breast cancer diagnosis, and out of that massive group, only about 5% were actually prescribed vaginal estrogen.
Which really highlights just how deeply entrenched that fear and avoidance is within the medical community. I mean, only 5% of these women receive the most effective treatment for their pain.
But for that 5%, the results are staggering. The researchers looked at the risk ratio for breast cancer recurrence over a 5-year period. And for women with estrogen receptor-positive breast cancer, the exact type of cancer fueled by estrogen, the risk ratio was 0.94.
Which is incredible.
Huh.
A risk ratio of 1.0 would mean there was absolutely no difference in risk between the women who took the estrogen and the women who didn't.
Right.
A ratio of 0.94 actually trends slightly below the baseline. So statistically, the conclusion is concrete.
Right.
There was no increased risk of breast cancer recurrence for the women using vaginal estrogen compared to those who avoided it entirely.
None. Zero increased risk. And that is backed up by another major piece of research, the Danish observational cohort study.
Yeah, the Danish study looked at over 8,400 women with early breast cancer. About 23% of them were prescribed vaginal estrogens.
Okay.
And after a median follow-up of almost 10 years, so tracking these women for a decade, they also found no increased mortality risk for those using vaginal estrogens.
So we have real-world data from tens of thousands of women proving that we can treat the local parched tissue of the vagina without creating a systemic environment in the blood that feeds dormant cancer cells.
Exactly. It proves that local therapy truly remains local. However, we cannot paint with too broad a brush here, and this is where the oncology clearance guidelines become incredibly specific.
Okay.
While the overarching data is highly reassuring, the clinical path forward is not identical for everyone. There is a strict clinical fork in the road, and it depends entirely on the exact type of life-saving drug the patient is currently taking to prevent their cancer from returning.
Right, the adjuvant endocrine therapy. And this is where we really have to talk about the two main players, tamoxifen and aromatase inhibitors, commonly called AIs. Let's look at the mechanisms, starting with tamoxifen.
So tamoxifen is what we call a SERM, a selective estrogen receptor modulator. It basically works at the cellular level. It travels through the bloodstream to the breast tissue, finds the estrogen receptors on the outside of the cells, and physically binds to them.
It plugs the lock.
Exactly. It plugs the lock so that any circulating estrogen in the bloodstream cannot attach to the cell and stimulate growth.
So tamoxifen is essentially like putting a bouncer at the door of the breast tissue.
Well,
Even if a little bit of rogue estrogen from a vaginal tablet makes its way into the bloodstream, the bouncer is standing right there at the receptor and won't let it into the club.
that's a great way to put it. And that bouncer is highly effective. Because the cellular doorway is actively guarded, oncologists are generally much more comfortable prescribing local estrogen to women taking tamoxifen. They have a safety net.
But then we have to contrast that with the other major class of drugs, right? The aromatase inhibitors.
Yes. AIs do not block receptors at all. Instead, they attack the supply chain. They stop the body's enzyme aromatase from converting androgens into estrogen in peripheral fat tissues.
Got it.
Their goal is to completely deplete the body's estrogen supply, resulting in virtually zero circulating estrogen.
So if tamoxifen is the bouncer and AI is like a total citywide prohibition on alcohol, there are no bouncers at the clubs because there isn't supposed to be any alcohol in the city at all.
Exactly.
Even one drop is a violation of the rule. Is that why oncologists get so incredibly nervous about combining AIs with vaginal estrogen?
That's exactly why. Because there is no bouncer guarding the breast tissue receptors, the fear is that even a tiny transient bump in systemic estrogen from a vaginal tablet could reach those unguarded cells.
Ah, I see.
Theoretically, that tiny amount of estrogen could negate the life-saving effects of the AI. In fact, that Danish study we mentioned earlier, while it found no overall increased risk for the vast majority of women, a subgroup analysis did show a slight increase in recurrence risk, specifically for women who were concurrently using an AI and vaginal estrogen.
Wow. So the prohibition environment is highly sensitive, which means we need a very specific action plan.
We do.
We know the non-hormonal route is step one. But if a patient is on an AI and their life is just being ruined by severe GSM, what are the oncology clearance guidelines? How do they get relief without violating prohibition?
Well, the guidelines, particularly the consensus from the British Menopause Society, suggest a very structured pathway. If non-hormonal treatments have failed a woman on an AI, the next step isn't immediately to add estrogen.
Okay, what is it?
The first step is for the patient and her oncologist to discuss switching her breast cancer medication entirely.
Switching from the AI to tamoxifen.
Exactly. By switching to tamoxifen, you introduce the bouncer to the breast tissue. And this change alone can sometimes alleviate the severe joint pain that is frequently associated with AIs.
Oh, that makes sense.
Once the tamoxifen is established and guarding those receptors, the oncologist and menopause specialist may feel much more comfortable introducing a 12-week trial of low-dose vaginal estrogen.
But what if a patient can't switch? What if the AI is absolutely the best or maybe the only drug to keep her specific cancer at bay?
In that scenario, If symptoms are severe and non-hormonal options have absolutely failed, a low-dose vaginal estrogen trial can still be considered. But it requires what we call deep shared decision-making.
Okay.
The patient, the oncologist, and the menopause specialist must sit down together. They have to weigh the theoretical uncertain risk of cancer recurrence against the very real, absolute certainty of the patient's current daily suffering.
So it's about looking at the individual context. The sources outline that factors like the stage of the original disease, how long it's been since the diagnosis, and the severity of the symptoms all play a massive role. Like if a woman had a low-grade tumor 10 years ago, but her current quality of life is completely destroyed by GSM, the math on that risk-benefit analysis looks very different than for someone newly diagnosed with a highly aggressive tumor.
Absolutely. This interdisciplinary communication is the key to unlocking this relief. The patient often gets trapped in a medical silo.
Right.
The oncologist is laser-focused on preventing the cancer, while the gynecologist is terrified to touch the oncologist's treatment plan. No changes to breast cancer medication and no initiation of hormone therapy should ever happen in a silo. The doctors must communicate with each other.
And we've been intensely focused on breast cancer because it's so common and so directly tied to estrogen. But what happens if the cancer was actually located in the reproductive organs themselves?
Oh, right.
If we are looking at cervical cancer, or vaginal cancer, or vulval cancer, do these same strict prohibition rules apply?
Interestingly, the landscape for gynecological cancers is starkly different. When we look at cervical, vaginal, and vulval cancers, the guidelines from the British Gynecological Cancer Society are remarkably clear.
What do they say?
They say vaginal estrogen and even systemic hormone replacement therapy, or HRT, is overwhelmingly safe for these survivors.
Wait, really? Even though the cancer was located right there in the reproductive organs?
Yeah, it's safe. The safety profile is dictated by the mechanism of the cancer's origin. The vast majority of these cancers are not hormone-driven.
Oh, I see.
For example, cervical cancers are almost entirely driven by mutations caused by the HPV virus, not by estrogen exposure.
Right.
Even for a vulval melanoma, the cancer originates from melanocytes, which are pigment cells, not glandular tissue that relies on estrogen to grow.
Yeah.
A massive meta-analysis showed that using HRT does not increase the risk of recurrence for these specific cancers.
But the treatments for these cancers, like radical surgery or pelvic radiotherapy, can throw a woman into sudden, severe menopause, right?
Devastatingly fast. The treatments cause catastrophic tissue damage and immediate GSM. But because the original cancers don't feed on hormones, there is no medical contraindication to using local estrogen or even systemic HRT to heal that pelvic tissue and manage the menopause symptoms.
That is incredible to hear. Are there any exceptions in the gynecological cancer space that women should be aware of?
The primary exception is a rare condition called endometrial stromal sarcoma.
Okay.
For that specific diagnosis, which originates in the connective tissue of the uterus and can actually be hormonally sensitive, HRT is generally avoided. Unless, of course, the quality of life benefits for the individual vastly outweigh the specific risks.
Makes sense.
But for cervical, vaginal, and most vulval cancers, hormone therapy is a safe, highly effective tool that really should not be withheld out of generalized fear of the word cancer.
It is so vital that we separate the specific biology of breast cancer from other cancers rather than just applying a blanket, no hormones for anyone who has ever had cancer rule.
Exactly. It all comes back to treating the unique patient sitting in the exam room, understanding the specific mechanisms of their disease, and really valuing their quality of life as a vital medical metric, equal in importance to their survival.
To bring this deep dive to a close, let's distill all of this down for you. If you are navigating life after breast cancer, the first thing to know is that systemic hormone replacement therapy, the pills and patches that flood your whole body, that remains generally off limits.
Yes, generally off limits.
However, your genitourinary suffering is not mandatory. It is not just a cross you have to bear for surviving.
Right. Start with the non-hormonal options. Find the paraben-free moisturizers and use them consistently.
But if those fail, know that you are not out of options. The modern data, backed by tens of thousands of real patient records, increasingly supports ultra-low-dose vaginal estrogen as a safe option that does not increase breast cancer recurrence, especially if your body is guarded by tamoxifen.
And if you are on an aromatase inhibitor, the path requires a bit more clinical navigation. It might mean discussing a medication switch with your oncologist or having a serious documented risk-benefit conversation about trying a local estrogen trial. The most important takeaway from all of these guidelines is that interdisciplinary care is your fundamental right as a patient.
Absolutely.
Demand that your oncologist and your menopause specialist talk to each other to form a cohesive plan.
Armed with this specific data regarding AIs, tamoxifen, and these massive recent studies, you can now walk into your doctor's office and confidently advocate for your own comfort, your health, and your intimacy. You survived the fire. You shouldn't be forced to live in the water damage.
I'd love that. A life saved should be a life lived fully.
Yes, so I want to leave you with a final lingering question to ponder today. If massive modern data sets are entirely contradicting the FDA's blanket black box warning on local estrogen, a bureaucratic warning that has terrified doctors and kept millions of women in unnecessary pain for decades, what other long-standing, terrifying medical warnings are we accepting as absolute gospel that might actually be preventing patients from getting life-changing relief? Until next time, keep diving deep.